Ladies and gentlemen, let's welcome Doctors Short and Brooks.
Good evening, everybody. Thank you for joining Dr. Short and myself again. Today we're going to cover managing traumatic dental injuries. I wonder just how many injuries do you see, traumatic injuries, patients do you see per week? And how many do you feel you manage them well, or how well in your practice as a general dentist? We'll be discussing today traumatic examination, pulpal management and treatment, types of injuries. What is the best treatment for immature tooth when you have trauma to it with no symptoms or pathology? Some of the things you'll be remembering. Immediately after trauma, is a pulp usually acute? What are some of the medications you may use to treat this? But with no more ado, let's head on with Dr. Short and get started. And we'll be discussing this as we move along for this hour. Thank you for joining us. Dr. Short.
Thank you, Dr. Brooks. It's great to be with you guys again, and just hats off to the National Health Service Corps and everybody that's affiliated with this great organization. And I've had a blast being able to give several lectures and several webinars with you guys. You guys are very interactive and very informative, and that keeps our engines going and keep our minds turning so that we can help you be better at, especially with tonight's topic, managing traumatic dental injuries. So we're going to just jump into this thing, and be sure to, if you have any questions or any comments, like the moderator John said, just type those into the Q&A box, and Dr. Brooks will address that and read it to me, and then we'll be able to answer those. So let's jump in here. I do have to read a disclosure statement. In compliance with the American Academy of Family Physicians guidelines, I hereby declare I do not have financial or other relationships with the manufacturers of any commercial services discussed in this educational activity. Also, the information presented in this presentation is designed for educational purposes only. The reproduction and/or selling this material is unauthorized unless approved by Dr. Rico D. Short and/or the American Association of Endodontists. I can be reached at dr.short@yahoo.com or the AAE.org. So here are some objectives we're going to talk about on trauma. Trauma examination. How do we actually look at a patient when they come in with the trauma? What are some of the things that we look at? Secondly, pulpal management and treatment. And also thirdly, we're going to talk about types of injuries. When you have a trauma, especially with immature teeth, it's very important to keep them alive. I can't begin to tell you how many kids I see come in my office and they're 6 years old, or really anything under 9 years old, and they have a trauma with the tooth. And the first thing some dentists want to do is do a root canal. And that may be necessary down the road, but initially we want to evaluate and try to make sure that we can maintain the vitality of the pulp. And by maintaining the vitality of the pulp, you're going to get a better result if you have to do the endo down the road. And also, too, that's going to actually strengthen the dentin if the pulp can stay alive. And we're going to be talking about some of these things as the presentation progresses. Who gets hurt? When you have a dental trauma, who gets hurt? Well, there are two people that get hurt, or two things that get hurt. Of course, the person, the kid, and also the tooth. And not only just the tooth, the nerve gets hurt as well. So this is a perfect example that what we're talking about. This right here is a non-complicated crown fracture, meaning that it's not involving the pulp. Most of the time, you can just bond this as long as the patient is asymptomatic, and usually they'll be fine. Let's talk about examining trauma patients. When we get a trauma patient, one of the first things you want to do is take a thorough medical history. That's really important with what we do, because that can dictate how we're going to treat this case. Do a clinical exam, and also take different types of radiographs. With the medical history, we want to also check them out from a neurological standpoint. You want to make sure that they are cognitive and they know what's going on, because sometimes, if they're not, sometimes we have to have some medical intervention as well, maybe even get an oral surgeon involved. And we also want to get a history of the injury, what type of injury it was, because sometimes this can dictate the type of treatment that we're ready to render. I want to do a clinical exam. The clinical exam includes the extraoral exam, look at the mouth, the lips, the face, intraoral exam, and also you're going to take radiographs. And there are several radiographs that you can take other than bite wings, such as some PANS, panoramic x-rays, and also sometimes you may want to take some occlusal x-rays as well, especially if you think you're dealing with a traumatized tooth or a subluxation, which we'll talk about later on in the presentation. With the extraoral exam, you're going to look at the general condition of the face, the head and neck findings, facial fractures, see if there are any, and soft tissue exam as well. Intraoral exam, you want to do a thorough dental exam, and also you want to do some pulpal evaluation, which we'll talk about that later. Pulpal evaluation, when you initially check the pulp status for some of these teeth, especially if they're freshly injured, they may not always be accurate. You can have something what we call a concussed pulp, meaning that basically the nerves in the pulp are kind of out of sync, if you will, and sometimes it can take quite a bit of time for the nerves to actually reorganize and give you a positive response. So sometimes you may get false positives with those.
Doc, time-wise,
Yes,
with that type injury, how long would you think it would take to get a real accurate reading? A day, a week, months?
well, sometimes it can take months. Some of the studies showed, Dr. Brooks, that sometimes it can take up to a year before the pulp actually comes back and responds normally. In the meantime of that, you do have to get the patient back on recalls, and you want to actually continue to establish baselines as you bring the patient back. Now, if symptoms involved or you see something going on in the x-ray, then you have to intervene. But if the patient is asymptomatic and you don't see breakdown, sometimes you can wait up to a year. I personally think a year is too long, personally. Usually I give it about sometimes anywhere between 12 to 16 weeks. But we're going to be talking
Okay,
about that
Doc.
later on. That's a great question. Thanks. Talk about radiographs, what we mentioned before, um, various views with different types of radiographs. One thing I want to bring to your attention, the AAE, you can actually go to their website, which is the www.aae.org, and it talks about emergency management of the avulsed tooth. And the reason why I didn't want to put a whole list of it, because they kind of have a step-by-step flow chart, if you will, of that, which to me is kind of redundant. But sometimes these things change. In fact, the past couple of years, I think the management of some avulsed teeth have changed probably in the past 5 years 2 or 3 times with the AAE, because as you get ongoing research, we find out, hey, we should do it this way, that way, what's the best solution to put the tooth in. So these things change. So the most current guidelines can be found at the www.aae.org, as well as the emergency and follow-up management of other dental alveolar injuries. They also can be found at the www.aae.org, which is the American Association of Endodontists. Like I mentioned before, vital pulp promotes root development, and that's what we want, especially when we're dealing with these immature teeth, because it's going to be very difficult to try and obturate a tooth with a really wide open apex, and we're going to show you some slides on that. Have any of you guys heard of the term apexogenesis?
Oh,
Dr. Brooks, you've
yes,
heard of that term
yes.
before, right? Basically, with apexogenesis, just like the words say apex, meaning the end of the root, genesis, that means you're trying to grow or form something. You need vital pulp, and that's exactly what we need in a case like this. You can look at this slide here to the left, that this was a traumatic injury here involving the pulp. And the other slide to the right is showing that with the technology we have, that we can actually put MTA, which I'll talk to you about, and put it on the pulp, restore it, and we can also keep the pulp vital and have those dental walls thickened to give you a better prognosis down the road if you have to go and do endo on it. This is a case that I had, a 7-year-old female. She fell down and traumatized tooth 9. And tooth 9 actually was non-vital, and tooth number 8 was vital. So what do we do? Anybody have any guess of what do we do? Nothing. We didn't do anything. The patient was asymptomatic, and we said we're going to give it some time. So I brought the patient back in 8 weeks, which is 2 months, and all of a sudden the tooth is vital. So thank God we didn't go in there and start extirpating the pulp or messing with the pulp too early, because of the mere fact that these things actually a lot of times will revascularize. In fact, if you actually look at the apex, long as the studies show, Andreasen, which is one of the biggest gurus in endodontic trauma, if you at least have 1 millimeter or more of apical opening, um, the studies show that vascularity has a high chance to form, at least about 80 to 85%. Once it actually closes off or domes off, and that gets less than a millimeter here, and then those chances dramatically decrease. And it really makes sense because usually this tooth comes in the mouth at the age of 6. It takes about 3 years for the root to completely form. That's 9. So if you do have a kid that you got to do endo on an anterior tooth, it's usually pretty safe and pretty easy, quote unquote, to do it at 9 and above because that apex is closed and you don't have to worry about extruding a lot of material in most cases.
Now, Doc,
Yes,
you
sir.
were saying the apex is a millimeter or greater. Is that at
Right.
time of injury? You look on the x-ray and determine at that time of injury, or when do you look to see if you've gotten less or more of that apex opening to create
Well, you want to look at it. It has to happen at the time of injury. That's the key. That's the key. The time of injury, then you can actually measure. And if the apex is at least a millimeter or more in width at the apex, then you got a great chance that you get revascularization there, and chances are, the pulp can survive
okay.
the
And
trauma.
now there again we're talking that 8 weeks, 16 weeks later to check it again. You give it time.
Right.
Yeah.
Right. Give it some time, unless symptoms come in.
And Miss Watson, I think, was asking what other medicine can you use with other than, was it MTA? Right.
That's a great question, Dr. Watson. And you know what? We found that you can use other materials, but nothing out there is as good as MTA. And MTA is the golden standard. We've had so many studies that show that this stuff is tried and proven that it actually will give us the best results. At one point, there were, before MTA came about, they did use calcium hydroxide, and it was okay, but the problem is the calcium hydroxide washes out, and if it washes out, what happens is you can get bacteria ingress. So at one point it was fine, but when the calcium hydroxide washes out, you got bacteria going back in there, and that also can kill the pulp or make the pulp non-vital. MTA doesn't wash out, so it's almost like a Portland cement, so it's there permanently, and actually it's osteoconductive, and it also is odontogenic conductive. In other words, we can get dentin to form against that as well. And but that's a great
And
question,
Doc,
Dr.
again with
Watson.
this time factor, because we all go in there do something, and in 2 weeks or a month it hadn't happened. But with the MTA, are you looking at that to take a month, 6 months? What, or just depends on the degree of the injury and degree of the opening?
Well, it really depends on the degree of the injury and the degree of the opening. And basically, I usually use MTA on a case where, and I'm going to tell you about what
Yeah, further
MTA
on.
is down the,
Okay.
later on in the lecture. Um, but basically, I'm dealing with complicated crown fractures involving the pulp. And basically, what I want to do is I want to make sure the remaining of that pulp tissue stays alive. And so what the MTA is going to do is going to facilitate that. And then you just place your composite material on top of it. And that is a permanent filling material. That's not removed. Some of the calcium hydroxide, some of that dical and all that stuff. There are some schools of thoughts when it sets up for a period of time, you have to go back in there and scrape it out and then restore over it. But that really, you introducing more microorganisms into the pulp, which is going to
Move
increase the
along.
chances of it dying out. So let's continue to follow up this case. So in 8 weeks, this patient was doing fine. Everybody's happy, mommy happy, daddy happy. Oh, we don't need a root canal in this tooth. So here it is. We got 1 year. You see what's happening? If you can look closely at this pulp chamber here, it's starting to calcify. So this pulp chamber is calcifying. So now we're concerned that, are we going to let this thing completely calcify, and if she gets problems, are we going to be able to get back in here? What do we do? So at this point, the patient was asymptomatic, so we decided we're going to continue to watch it. So this is 1 year. So here we go, 2 years. We brought the patient back. Now we got more calcification. Now the symptoms are starting. The symptoms were, it hurts when I brush my teeth, and when I touch on it, it hurts. So when we pulp tested it at that point, now the pulp is actually non-vital. So now it's time to do the endo. But you see the difference between this pulp. Imagine you trying to do endo on this versus the other tooth, number 8. This is, most of you guys see, this is a normal, quote unquote, pulp chamber anatomy that we usually see on adults. If you look at that, this is a lot more easier to manage than, say, for instance, this big wide open gap here. And on top of that, you see how much nice dentin we had form here just because we left it alone. So this tooth is going to have an excellent chance down the road because it's strong. We're able to get a good solid condensed fill at the apex, and it's also easier to manage. Not only that, guess what? This patient is older now. So imagine, there's a big difference between working on a 7-year-old and a 9-year-old. Usually they're a little bit more mature, they're not as afraid. So that also makes your life easier. And that's what you want to try to do in dentistry. You want to make your life easier. So the older the patient is, a lot of times the better they're going to be able to.
Another point you're making here, Doc, that you've stated before, is we have to follow up on these patients. We have to be patient. We have to get them in and educate the patient on what is occurring in their mouth. And in the case of a 9 and 7-year, also educate the parent.
Right. And that's key. I'm glad you brought that up. And that's critical because sometimes these patients will just kind of, oh, you're not hurting, they just disappear. And all of a sudden, if you're not following up, they wake up with a big abscess or they've been having pain. So when you get these patients on these recalls, you actually are monitoring. And I also write a letter to the general dentist and say, hey, there's a trauma. When you clean your teeth, take a look at them. And if you see anything different, and I even tell the patient, if the tooth starts turning dark, they start complaining, let someone know so we can get in there, so we can try to prevent, a problem before it blows up on them. So, so this is a tooth number 9. We started. This is about 3 years later, so we got a recall. So you see this huge open apex here. Excuse me. To this result, this is a favorable result. This tooth, if she ever need anything, ortho, whatever, this tooth will be fine to move around, versus the counterpart tooth. So, and this is sometimes that we dentists sometimes tend to want to rush into and fix a problem because that's how we're trained. But this is a situation sometimes we have to kind of scale back and wait. And sometimes the best treatment is not treatment at all; it's time, a tincture of time, so to speak. So let's look at this case. This is another interesting case of mine. Tooth number 30 with an open apex and a vital pulp. So how in the world, and this isn't necessarily a trauma case, I'm just kind of showing you how apexogenesis work here. This is a molar decay right onto the pulp here, and you see these apexes are wide open. Now, Dr. Brooks, I don't know about you, but I don't know. You think you'll be able to get a
that's
stop?
Why I refer to you,
down there?
Doc. That's why I'm going to send that person over. Even though I might have tried, he'll still end up in your chair. But no, I don't think we could have got it sealed off down there. Yeah.
Right, and maybe some of the participants, if maybe you guys can figure out, hey, what can we do with this case? So again, this was a case of a kid. I think the kid was about 6 years old or so, immature apex here. So we could not do conventional root canal on this case. So what we end up doing on this case is what we call an MTA pulpotomy. I'm pretty sure you guys heard of pulpotomies, spec pulpotomies, and all that. Pulpotomies with form of cresol, so on and so forth. But this is a special type of pulpotomy that we use for apexogenesis. And basically what we do, the technique is we go in there and we remove all the decay. You have to remove all the decay. But what you don't want to do, you don't want to remove all the pulp tissue out of the I call it the pulpal floor. You want to have some communication between the pulp tissues from the mesial to the distal. And with that, what we do is we lightly irrigate this area with some chlorhexidine or Paradex, because we don't want to use something to kill the pulp like bleach, sodium hypochlorite. So what this does, this kind of renders the pulp, almost kind of, it doesn't make it bacteria free, but it kind of sterilizes it a little bit so that we can maintain the rest of the pulp vitality.
Now,
so
what age is this patient here, Doc?
So this is kind of like a multi-rooted form of what we saw earlier.
Traditionally, when I was in school, you went in there and cleaned everything out.
Yeah.
Put the form of cresol, and then you've built it back up. So you're saying we don't even brain that out at this point to save this tooth? Yeah, that's what I'm saying. Yeah.
Now this is a permanent. This is a permanent tooth. Right, right. Yes. No, we don't even we don't do that anymore. You know, MTA, like I said, it has so many uses for this stuff, and it works so well that it is actually the gold standard when you're doing some of these procedures. So we're going to be talking about more about that, but
Oh
let's follow
yeah.
this
Oh
case.
yeah.
So here it is, a
Right.
1-year recall showing apical
Right.
closure progressing. So you can kind of see this, that we're getting some progression, and you see what we have on here, stainless steel crown, and this is after a year. So let's continue to follow this. And guess what? This tooth still responds vital.
Mm-hmm.
So you put cold on it, they feel the cold, which is great. And that's how we test to make sure that this tooth is still going to be fine. And you kind of figure, he's like, man, how can this respond vital
Right.
when
Right.
you took some of the pulp tissue out? But remember,
So you're trying to really
we're
just
not
remove
severing
only the
the
decay
anastomosis on the
and the
floor.
pulp that might
So
have
you still
come in
got
contact with
communication
decay.
between there.
Yeah.
Um, Exactly, and I'm glad you mentioned that, because the other technique with that is that um, you don't want to use a round burr. You don't want to use that. What you want to use is a brand new diamond burr and get into what we call healthy pulp, a non-bleeding pulp. And
Okay.
usually you have to go a little bit further down from where the decay contacts the pulp to get into quote unquote healthy pulp. And what you don't want to use a diamond. I mean, you don't want to use anything like a carbide, because you don't want to pull the pulp tissue. What you want to do is sever it. You want to do a clean sever cut with it. So that's why these chamfered diamonds are really good at that, because that can actually just really sever it really well. And once you get into what they call healthy pulp don't bleed. And so what you'll do, you'll see a nice pulp stump there, and it'll be nice and pink, and it won't bleed. And that's how you know you're into healthy pulp. But this is a very technique sensitive type of procedure, and really I don't see how you can do it without microscopes personally. Maybe you can do it with some loops, but it'll be very technique sensitive. So here it is, the pre-op and 1-year post-op, so in that we do have some nice closure here. So everybody's happy. And I even got another 2-year recall for some of
Oh
the
yeah.
non-believers that say,
Yeah.
you know what, I don't think this works. So you can see here, look at that open apex. And can you guys see that the apex is actually closing up? And this is with no endo. This is no endo involved. Okay? So the term for this is called MTA Pulpotomy, to facilitate apexogenesis. So if you ever on Jeopardy or something like that, that'll be the answer. Just kidding. So here we go. Um, 5 years later, it becomes necrotic. But guess what? This guy, he was at 6. He was a very difficult patient. Nitrous, I had to use
Mm.
everything. At 11, he's a totally different guy. He's comfortable. We didn't have to use the nitrous. He was like, hey, do what you have to do. So we went in there. The pulp became necrotic, and we had to do endo on him. And he did fine. And so he still have this tooth that otherwise had a very hopeless prognosis, 5 years ago, trying to do it the conventional way. So
Eh,
we talk about apexification, which is another thing we're going to talk about. These involve non-vital pulps. And guess what else can be used for apexification? MTA. MTA can be used for apexification, which we'll talk about. So basically what this is that if you have a non-vital pulp, that means you have a trauma and the nerve does not come back. I mean, it is finished. So that means that you cannot get no revascularization. Nothing's going to happen. It's going to stay like that, become necrotic, cause an infection. So there's a procedure we do called apexification. There's an MTA apexification, or technically an immediate apexification. We go in there, we clean the pulp out. We'll place calcium hydroxide, which is usually our medication of choice. We'll leave it in there for a few weeks. We'll take it out, and then we will actually put in, we call it an MTA plug, to plug up the apical extent, probably about 3 or 4 millimeters. And if you want to use MTA during the whole canal space, you can, or you can just use MTA at the bottom. You can fill the rest up with gutta percha. MTA is very expensive. It's approximately, don't quote me on this, but it's probably about close to
Now,
$100 a
Doc, are you
gram for it.
determining
So
this on
it's pretty
the
expensive
initial
material. So you want to
examination,
basically
or have
use
you
it
given
use it
this
with
tooth
care. But
the
it
weeks to
really
try and
works.
revitalize? That it's right. Okay.
Well, you want to give it
Okay.
you want to give it the time to
Okay. And now,
become
okay.
vital again. But if it doesn't and they get symptoms, you know
No, no,
what you're dealing with.
I think you're showing it
It's
here.
over. You know.
Yeah.
So you have another question? Okay, so this is what we're showing here. This is a case, got things cleaned out and medicated, and we brought the patient back and we did immediate pexification. This is the MTA plug, and basically MTA is here, and the rest of the root canal is filled with gutta percha. So you can see here, and basically what that MTA is not only adonogenic or dentogenic, is also
And
osteogenic.
there
So
again,
the
you're
tissues, the
placing
cells, they
it
love this stuff.
and
In fact,
planning
the
to leave
PDL
it
can
in
actually form
place.
around it as well. I mean, it is a super duper
Okay.
biocompatible material.
Okay.
Yes, it is there forever. It's there. So let's talk about calcium hydroxide. There's actually three types of calcium
Right.
hydroxide, but as endodontists, we only use basically two forms, which comes in a paste or a powder. Now, this is a different calcium hydroxide from dical that we probably learned in dental school. This is what we use pretty much for endo, and it all depends on the case. Sometimes we have to use the powder. Sometimes you have to use the paste. The paste comes in an injectable form. The powder comes in like a little USP pack, and you actually mix it with sterile saline, or you can mix it with anesthetic. So it depends on what you're trying to do on the case. Typically, if you have just a regular non-vital case, you can actually use the paste and just squirt it in there. If you have something with a wide open apex, you just don't want to squirt the paste in there. It goes all over the tissue. So then you actually use a carrier. You mix it up as a thick consistency as a paste. Use like an amalgam carrier. You pack it in there, and that's how you would use it for that. And I may have a few cases I can show you about that. So let's talk about calcium hydroxide. Some of the mechanisms of action: it induces a necrosis of all cells. Um, in experimentally induced inflammatory resorption. So this thing doesn't just kill just necrotic tissue. It actually can kill some of the vital tissue as well. And sometimes you have to be careful about getting it too far out the apex because it does induce pain. Patients will call about some pain, and you have to give them appropriate medications for
Now, is
that.
that pain
Sometimes we
something
can
you
call
would
that a
have to go
flare-up
in and
with that. So
treat,
you
or
have to
will
be
just
pretty
go away
careful
with
with this
time?
stuff. If you get a little out the apex, it's usually okay. But if you get a lot out of
Right.
it, they will complain about they're in some pain. It'll just go away with time, but you just want to let them know so they won't be, too alarmed when that happens. It reduces PDL inflammation. It inhibits clastic cells, so if you have some resorption going on, it helps with that as well. Stop bacteria from entering the canal. Kills any bacteria that have entered the canal during the injury. The only one species of bacteria we know it has a hard time is
Mhm.
Enterococcus fecalis, which is one of the main species that's there in retreatment cases. So that's one of those ones that it doesn't do quite so well with that. And also calcium hydroxide inhibits fibroblasts so that you can get great healing, osteogenic healing, and also, you know, it can create some ankylosis if it's left in there too long.
Mhm.
And what I mean by too long, the current recommendation is they don't like calcium hydroxide to be left
Now,
in there any longer than a month. Over a period of time, it can
okay.
actually start
Question
weakening the
now.
tooth as
With
well.
the calcium hydroxide, you go back in
Let's
a
talk
month or
about some
so,
pulp
remove
capping.
it.
Traditionally, pulp
Right.
capping, what do you use? You use pretty much what? Dical.
Yeah.
Okay. Well, the calcium hydroxide, that's a great question. The calcium hydroxide, we don't necessarily have to
Okay.
go in there and remove it until we're finishing the case because what happens is as the body is using the calcium hydroxide, it will actually just absorb by itself and it'll just
Mhm.
kind of go away. In fact, there was one school of thought if you have a wide open apex, say for instance a number 9 and it's draining a lot. I mean, you know how you used to be taught that leave teeth open. What happens is now instead of leaving teeth open, which we found out is a very bad idea, um, what you do, you can mix a very thick mixture of calcium hydroxide once you open the tooth, clean it out really well, and you just pack it in there. And once you pack it in there, that moisture or the weeping or whatever you want to call it interacts with that and it actually stops. So you kind of plug it up. But what happens, and then you put the temporary filling in there. And what happens over a period of time, the calcium hydroxide leaches out. until the inflammation is gone, until everything is gone. So you go back in there, you don't have a weeping canal anymore. And on those cases, I usually let that soak in there for about a month. And I go back in there, it's dry. And that was one of the keys that I guess at one point that even endodontists, they were taught, and general dentists sometimes was taught to leave the teeth open because we didn't know how to stop the draining. And we were afraid that these patients were going to leave and they're going to have a bad flare-up. But what we found out is that the calcium hydroxide powder, if you pack it in there really well, it actually leaches out over like a time release type of thing. And it actually decreases the inflammation out into the tissue. Right, you come back and you obturate it, whether you use the MTA as a, well, now we use MTA, but at one point, when we didn't have MTA, what we have to do is keep putting calcium hydroxide in until what happens is you get a barrier, you get a osteogenic cap over the end of the root. And then once you get that, that's your stop. And so once you put a piece of gutta percha in there, it's not going to go any further than that, and then you obturate it. So when you use calcium hydroxide for an extended period of time, what you can get is that cap, with an osteogenic cap, and then you're fine. But what we found out is that too long calcium hydroxide isn't good, and that can also weaken the dentin. So now we're really going to just usually 1 month of calcium hydroxide and trying to get some MTA or something like that in there. The plug at the bottom, we obturate the whole case with MTA. Yeah. So let's talk about a little pulp capping, small pulp exposure soon after injury. At one point, dical or whatever was fine with that, but we recommend pretty much MTA as the standard for pulpotomies, which is a large pulp exposure. If it's hours or days after the injury, because we already know that we got bacteria ingress, so we got to take out more tissue. So if it's a small area, you can do some pulp capping. For me personally, I've seen cases where I've seen pediatric dentists put like a little dical there and pulp cap, but these things will still flare up. When we do MTA, that just doesn't happen. It just doesn't happen. So this is a case where there's a complicated crown fracture here involving the pulp or the nerve here. And this is actually showing some MTA placed, and the tooth was restored. And this is something that we would watch. We wouldn't just go in there and do the endo, because the apex is still open, and this is a kid, and we'll just watch that. Are you guys still out there, participants? I see we got 19, so hopefully no one's out there sleeping. You guys ask some questions, and you know, let's get the. Maybe you already know all this. Maybe you already know all this stuff, which is great if you do. So let's talk about luxation injuries. The World Health Organization has classified these in different categories. We classify them in minor luxation injuries, which are concussions and subluxations, and also major luxation injuries, where these things actually move out of the socket, where you're talking about lateral, extrusive, or intrusive luxations. Let's talk about some of the lateral. Lateral luxations is basically when the tooth is moved laterally, not completely out the socket. Extrusive luxations, meaning that it actually moves vertically, not completely out. If it's completely out, it's called an avulsion. Intrusive luxation, this is one of the worst kind of luxations you can have, especially on a permanently tooth that's the apex is closed, because this crushes everything, crushes the ligament, crushes the PDL, crushes the blood supply, and pretty much severs it. So
now, which comes first, endo or ortho?
99.9% of the time, they will need endo on this tooth, and they may even actually need ortho to actually pull the tooth back down into position. Okay. Well, it all depends on the symptoms. If the patient has the symptoms, you know, and if it's hurting, if it's painful, and then, you know, you want to go and do the endo first. And then once you do the endo, you can go ahead and put a chain on it or whatever and pull it down. If the patient really don't have that many symptoms as far as endo symptoms, and, you know, if they're doing okay, the tooth stays vital for at least for a little period of time, you may can try to pull it down. But most of the time, I usually recommend go ahead and doing the endo on these. That way you don't have to worry about them being in pain when you put that chain on and pull it down. So let's talk about extrusive luxations. These are partial displacement of the tooth out of its socket. So you can see here, we got some points here where the actual tooth is actually has been kind of sort of ripped out of the socket there. And lateral luxations, you can see that these things actually they displace the tooth in a direction other than actually what we talked about before. And this is accompanied by crushing or fracturing the alveolar socket. Sometimes these teeth can actually get locked in. Like, depends on the fall, they get locked in. And what you have to do, you can't just snap it back in place. These actually have to be pulled down first. I know I mean, sounds kind of crazy. You have to pull it down and also tilt it and push it back up. If you try to push it straight in, you're actually going to break the root and you're going to crush this alveolus right here. So you're going to create more problems. And a lot of times, if you're not skilled and you don't really understand how or remember your anatomy, you can actually create a worse problem. So these actually, you have to pull it down like you're extracting it, and you'll hear a pop, and then you actually tilt it back, tilt it lingually, and then you pull it in, and it'll just go right back into the socket there. Pulp testing, we talked about that, can cause the shocked pulp. About half of these teeth with luxation injuries do not respond to pulp test. A return of positive testing, usually seen within 2 months, but can be seen up to 1 year. Following a trauma, vital pulp may exist without a viable nerve supply. A vital tooth may not respond to pulp testing initially. So these are some clinical features you may see with extrusions. They appear elongated. You'll get some bleeding from the PDL, and some mobility will be present. With the lateral luxations, well, and also from a radiographic standpoint, you can see here you got increased PDL space. You may need an occlusal X-ray. Remember, we talked about that before, different types of X-rays, and also a PA. Clinically, on lateral luxations,
now eventually all of these will need endodontic treatment.
And also when you tap on it, you'll hear a high metallic sound with percussion. Right. And usually no mobility, and usually that's because they can be locked in place. Eventually, more than likely, with that apex closed, remember we talking about at least have to have a millimeter more? Yes, they will eventually need endodontic treatment. And you want to stabilize, what I'm going to talk about first. You want to stabilize the alveolus, stabilize
now,
the
with
PDL
stabilizing, how is
two weeks,
glue them together with the composite, or there's a strip you put on the back, or how would you suggest doing that?
The pulp sooner than that. So it all depends on what's going on. All right.
Oh, let's see. Here we got
we're gonna be talking
very
about
informative.
That. Hold tight. We're
this is
this is show some pictures there.
It's great. Keep it going. What are your tests? Cold, electric, or both? Hot.
Yeah. Our group is waking up tonight. Great. Great question, Dr. Watson. My main test is cold, especially when you're dealing with trauma. Most of the studies show that electric pulp testing when you deal with trauma is really, really one of the most inaccurate forms of it. So electric pulp testing, for some of you guys don't know, that's kind of like one of those ones that I use if I can't really figure out what's going on. But the cold test and the hot test are usually the major tests that we use for testing pulp vitality. If we're not sure, and I'm going to tell you a really good reason why I would use EPT, electric pulp testing, is when we're dealing with older patients with very calcified pulps, because the temperature is not going to go through that thick dentin and enamel. It just won't. And what you'll think is the case is necrotic. But when you put the pulp testing on there, electric pulp tester on there, it'll actually ring out. And that's why you know that you don't mess with that pulp. Okay. In fact, I would throw a number out. Everybody 70 and above probably won't have no cold sensitivity. We put the endo ice on. I don't feel cold. I don't feel cold. That doesn't mean all their pulps are necrotic. It means that they have resorbed. They have the dentin has thickened, the cementum has thickened, so you won't get that thermal.
But now you can use a cold on a crown.
The electric part, you will. The only problem, drawback with the electric
and by cold, we don't mean a carpet on the freezer.
You can't electric pulp test through crowns or bridges.
Okay.
So you have to find a contact point on some enamel or some dentin somewhere. Yes. 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 Right. That's kind of outdated. You know, the best cold test that I recommend is not ice out of freezer, not a carpio or whatever. You have to buy the I call it endo ice. And you basically spray it. I rather spray it on a cotton directly versus on a Q-tip. A lot of people put on a Q-tip outside their train. The problem is you put it on a Q-tip, especially if it's wooden, the wood is actually going to absorb some of the cold, so you're
Okay,
gonna
and then
be up
Doc,
a
we
few
have another
degrees. If you
question here
spray it
from, is it
directly on
Dr.
that
Noon?
cotton, probably damp it one
Can
time
you
on
download
the
this
patient, be able to go
PowerPoint?
straight to
Now,
the
I
tooth.
believe it
That's going
is
to give you a more
recorded in the
accurate
library as
response than
somewhere, Dr.
putting it on
Noon.
the Q-tip
Yeah.
with the wood, because the wood is going to draw that cold out and it
Accessible.
won't be as cold. Yeah.
Yeah, and here's another one from Dr. Harris. Should extruded tooth be pushed back into the socket and
Right. I
splinted?
think yes,
And
it
you were
will
going to
be
talk about splinting later
recorded,
on.
accessible at some point, and you'll be able to refer back to it. Um, Yes, ma'am. Dr. Harris, we're going to be talking about that. That's a great question, but just a short version is that extruded teeth should be pushed back into their socket as soon as possible and splinted, not with a rigid splint, but a physiological or light splint, a fishing line, monofilament, something that's going to allow that PDL to move so that the tooth will know that it belongs to it. If you rigidly splint teeth with trauma, what you're going to introduce is resorption. That's what you're going to do because teeth are normally used to moving in the PDL. So that's a great question. But we're going to be talking a little bit about that. Here we go. Repositioning. Great question, Dr. Harris. That's what we're talking about now. You want to do it as atraumatically as possible when you reposition, because if you don't, like I mentioned before, especially with some of these lateral luxations, you can elicit further trauma, and also you can create other problems with the healing. And also, if you want to make sure the occlusion is close and the aesthetic demands are close, it requires really, careful repositioning as well. So with extrusion, local anesthetic is generally not necessary, you know, um, because the tooth isn't completely out the mouth. You can just kind of push it back in place. I prefer use local anesthetic on everything, personally, but some of the studies show that you don't necessarily have to do that. Lateral luxation, of course, you are going to need local anesthetic because you got to pull these things out and around that bone, and you may need to use some forceps. If it's delayed 3 to 4 days, reduction should be deferred. Should wait on it, and the tooth allowed to realign itself or orthodontically. Most of the time, it won't realign itself, and you have to get some ortho involved. So this is stabilization. So splint as short as possible and as long as necessary. I know that sounds kind of contradictory, but the splinting, excuse me, you want to do a non-rigid splint. This is exactly how you don't want to splint. When you're dealing with a tooth that does not have, or teeth that does not have alveolar fractures, because these can also lead to, like we said before, resorption and ankylosis. You want to use a passive splint, excuse me, that maintains the physiologic mobility of the tooth. So you can see here, this is, I believe this is
Now, Doc,
just like
you're
the
saying you
monofilament. This,
split it
this may
there,
be just
and
like
it
some
looks like
ortho
the
wire or something like
monofilament
that.
is
But make
just
sure you have
laying
something
on
around
the
your office,
teeth.
whether
Now,
it's
is it
ortho
actually
wire,
attached to the tooth
fishing
with
line would be great.
composite so it
They
doesn't
make
slip
some
out of place,
rib-on,
or
which
how do
is
you
like some
maintain it, or you twist it
composite, but kind
around
of
the
rubbery,
teeth
so
and
to
go to
speak,
the next one?
something
How
like
how
that.
do you maintain that in place? Hmm. Okay. 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 So it can
Well, if you
flex a
look at
little.
this slide right here, you'll be able to see how it's maintained. It's just composite, splint it right on, I mean, placed right on the facial aspect of the tooth with the wire. And this is some ortho wire, as an example. So you'll be able to see that, and you want to have some flexibility. Yes, we got some other
Right.
types, TTS splints, and monofilament nylon line like fishing line or whatever, you can actually use that as well. But there's no benefit extending the splint more than one adjacent tooth, so you don't want to necessarily have to splint all the way back to the molars, because that's really overkill. And also with the splints, you want to make sure these patients keep these things very clean, make sure they have Paradex, because if not, they're going to reintroduce microorganisms,
Now, Doc,
bacteria,
here's
and the sulcus, if
is
you have a
Dr.
lateral canal, it can
Mars.
go in there
What
and create some
size
problems with the
fishing
pulp
line
as well.
is ideal for
Splitting
splint?
time, stabilization, extrusive luxation, they recommend about 2 weeks. Lateral luxations,
Yeah.
about 4 weeks. And remember, this is all passive. Well, I'm not a. Well, if I was a fisherman, I'll be able to tell you the exact kind. But to be honest with you, it really doesn't matter because most of the fishing line is monofilament anyway. So it really doesn't really matter, the type. So whatever you have or whatever you choose to get, it should be sufficient. Post-op instructions. The goal, like I said before, is reduce the plaque. Brush teeth with a soft brush. Use chlorhexidine and Paradex to reduce the bacteria that can possibly go in there and create some more problems. Let's talk a little bit about internal resorption. Now, I'm going to kind of speed up through here because we're kind of running short of some time. Internal resorption, the features, the pulp is usually vital. And it's an oval shape and increase of the pulp space. So it's not a continuum of the pulp. You'll see the pulp and then you'll see it balloon out and you'll see it get back smaller. These are some possible causes: trauma, necrosis, plus infection of coronal pulp, but we really don't know exactly what causes these. But I'm pretty sure you've seen someone in your practice. This is the case that I treated, where you can see the pulp here and all of a sudden it balloons out and go back regular here. So these cases have internal resorption. And what I like to do is treat these cases in 2 visits. I like to place calcium hydroxide. Why do I like to place calcium hydroxide? Because there's really no way you're going to be able to clean circumferentially around this defect. So when you put the calcium hydroxide in there, it's going to fill up that little chamber there. And it's actually going to allow you to be able to clean and get some bacteria. Otherwise, you can't get a file into a 360-degree circle. So it's going to really help. Unless I maybe go out and invent some brush files or something like that that you would use and go around the corner or something. So make sure you participants don't steal my idea now. Just kidding. All right, let's go ahead and go to the completion here. And this is showing a nice little heart-shaped lesion filled with, this is just gutta percha here. And this is another case. This is a trauma on teeth 8 and 9. And basically, this kid came to me from a general dentist. The general dentist decided to do the endo. He said, "Oh yeah, I can do the endo. It's no problem." So let's see how this thing went. So this was the case where the general dentist finished it. And they say, Dr. Short, I need some help. I think something happened. I think I pushed some filling material a little bit far. And she's right. This is probably up into his nose here. And so again, this was a case where the kid, he was probably about 8 years old or whatever, and the apex wasn't quite closed, but she thought that she can just use gutta percha, and this is what happens. So we actually brought the kid back. We actually had to retreat this case because I was pretty sure she didn't get a good job cleaning out. And these are size 140 files or 160. So I don't know if you guys have any 160 sitting around your office, but that's a pretty doggone yeah, it's like a nail there. So we had to clean it out. Once we cleaned it out, you can see that we pushed the rest of the filling material out, which is okay, and because we're going to go in here and do surgery. So we actually cleaned it out. We got a really favorable result. So now we go in here, and this is all in one visit. I'll go in and do surgery, do an apical here, and actually clean that area up. So we removed that gutta percha. We clean everything up. We didn't do a retrofill with the surgery. We just actually ball burnished the tip because I know I had everything cleaned out well when I did the retreatment, and the patient was happy. So this is the case right here. This is tooth number 8. You see this defect here? What do you think is going on here, Dr. Brooks? You have any idea? Exactly. See, we got somebody that's not sleeping. Hopefully you guys aren't sleeping out there. Pay attention. That is resorption going on. So that's something that we would definitely want to try to get on the ball. Chances are with a resorptive defect that big, chances are this is already broken through the plate, buccal plate. You're probably going to lose that tooth. This is an interesting case. It was a 9-year-old. She had a trauma to teeth number 8, had an avulsion, and also number 9, intrusive luxation. So she had one that actually came out, and the other one that got pushed in. Now I don't know how in the world you can have that in one accident, but it happened. So, but she went to see her dentist. Her dentist actually put the tooth back, and they didn't even monitor her. So when she came to me, this was probably about 6 months after. You can see that the resorption already taken place. The tooth is mobile, and you can see these little Pac-Man look like lesions on the root. So her body don't even think that that tooth belongs to her. So osteoclasts are going and trying to eat this thing up. So we told the parent we'll go ahead and try to treat. We put calcium hydroxide. Remember we said I don't really like to use it but for a month. So we put calcium hydroxide in both teeth. And also, we brought the patient back. We completed. Number 8, we completed with MTA. This is MTA all in the canal space here. Why did I use MTA? I was concerned that we probably had some perforations in there, which we did. And also, I want to try to bring some more strength and rigidity back to the tooth. And also, there are some components of MTA that are very similar to calcium hydroxide as far as the osteogenic potential. So we wanted to do something to try to stimulate osteogenesis around this tooth as well. Then number 9, we just used regular gutta percha, and it did fine. So this is MTA. We call it our miracle material. There's only one company that sells it. That's Dentsply Tulsa, and they put a pretty heavy price tag on this stuff, but it works. It works. So what is MTA? MTA, a mineral trioxide aggregate, has the ability to encourage hard tissue deposition similar to calcium hydroxide effect. It also has the same biological and histological properties. The only difference is MTA is permanent, calcium hydroxide is not. And we use it for all kinds of stuff: perf repair, trauma, resorption, surgery, also regeneration techniques. So this is the case after a year. Patient still has the teeth, and her mom, very happy. This is 3 years. 3 years later. And if you look closely, guess what? We're getting some lamina dura. We're getting some PDL around this hopeless case that somebody was actually gonna take out on this poor girl. 5 years post-op. You see this? This is amazing. Look at this PDL space coming back. Look how it was. There was not the PDL was blown out. This tooth was mobile in the wind, and she still have it. And now it's probably going on about 8 years. And if we can get her to a point where she can get, hopefully in her 20s, if it fails at that point, it's great. She can get an implant there and be happy. So we're trying to maintain everything the best we can. So basically what you want to do, you want to give patients all options so they can make an informed decision. Because some of these cases that you see, you may look at them like, man, I don't even know where to start to treat this. If you have an endodontist around you or close to you, great. You talk to them and they can help you out. If you don't, we got the World Wide Web. You can always email me the case. I'll be more than happy to help you with it. And you can get my email at the end of the session. But you want to make sure that they make an informed decision. And if you're not feeling comfortable with some of these cases, hopefully this will be available for you online. As I did go through a lot of it very quickly, you can look at some of this stuff at your own leisure.
We got a couple of questions down here, Dr. Noon again. Did you have to splint that number 8? I think she's referring to the last one.
If possible,
on that
as long as you can, so that we can have a better
last
chance,
set of slides you showed,
a better chance to maintain longevity of these teeth. We got a little time to ask some questions. No, sir, we didn't have to splint that that tooth number 8. It was actually end up being like maybe a class 2 mobility, and this is one of the cases I had to make sure the occlusion was completely off.
That's the same.
But I wanted to see what the body
awesome review, Dr. Short.
Itself.
Thank you, Dr. Watson.
And if you give the body an opportunity, you remove the source of the infection, you'll be surprised at how well it heals, especially on young, healthy individuals. So, so no, I did not have to splint that.
Is that the one? I think that might be referring to the one that she asked, did you splint it also? Oh, okay. Yeah. And Dr. Short, there again with that case, it's very interesting how you follow up the patient.
Over with Dr.
And I think
Nuri,
you're able to accomplish this.
with
And
MTA
everything gets
had
followed up,
external
even with our
resorption.
help.
Yes.
If we go
Yes,
back
they
to
did
the
have
doctor, it
external resorption.
improves. So with them coming in to you to follow up, you're able to short stop something or make it happen that needs to occur.
That's correct.
And save those teeth. That's very interesting, that case, that last one. Yeah.
Right. And the key is you have to really educate the not only just the patient but the parents and let them know, because we can do the best cases, but if we don't get them to follow up, we won't know this stuff is working. I mean, and the thing is, I mean, I'm very fortunate to get not 1 year, 2 year, 5 year follow-up showing that this actually works. Now, I know that right now the latest and greatest things are implants, and I don't have anything against implants, but there's nothing is going to be better than your own tooth, which is the best implant. And a lot of these cases, would be extracted. I'm just going to be honest with you, because a lot of people don't know that as endodontists, these are the things that we can do. And I have plenty other cases that are that we can show, but due to a lack of time, I only want to show
also
you some of the
with
ones
that, Doc,
you can kind of see
I think
that,
we
wow,
need to be understanding that
work,
what you do
work.
maintains the bone, the aesthetics,
or if the patient
and the patient has a much better attitude when you have your natural teeth than if you count off how many implants I got up there. So mentally, they're better off. And then also, even like you say, you may have to eventually remove some of these teeth, but they kept them for 10 or 15 years, and then go to implants, because implants don't last forever. They have to be replaced. So if you're able to maintain a healthy tooth in there for a longer time, opposed to immediately going to implant at age 15, you've done a great service to the patient if they can get an implant at age 30. Yeah, so.
Right. Well, I'm glad you mentioned that, because some of the fallacies out there is they kind of present implants as the ultimate, and once you get that, you don't have any problems. And I don't have as much experience with implants, but I hear some of the reps are trying to get endodontists more into the implants, and they say, hey, you get this and it's over. I mean, you can just do an implant, but implants do carry a lot more complications.
And then it's the old adage that the more dental work you have, the better dental patient you have to be.
With that's kind of the hottest thing
with
out
the more
there.
implants,
Now,
that's a much more
one of those
technical,
where,
delicate situation. You have to be, they have to be much better dental patients, returning, getting them clean, making sure that the hygienists use a proper tool, you don't get them reinfected, because they're quite extensive if they go bad. It's a big problem if they go bad.
Right.
Right. Right. Right. Right.
Yeah, and then you got sometimes you have to go and do bone grafting, and you have all that other things. And then now you're talking about the older populations. What about these people that are bisphosphonate patients, actinil, or all those type of
it's not. And replacing the floor of the orbit
drugs and all
if an implant goes bad.
Osseointegrate. You go in there, you manipulate the bone.
Yeah. I mean, that has had to be done.
And you got some problems.
So,
and you got smoke.
Doc, I think he cued us, and we're kind of out of time here.
Very level playing
and
field to compare
let's see, especially
your own teeth, not just implants as a panacea, for everything.
Yeah. Yeah. Thank you.
Wow.
And then something about ankylosing. This last one, I think we're not going to be able to. Here's something here, Doc.
Yeah, okay.
GP 95% Medicaid pediatric dentist residency program.
A pediatrician.
Not a single endodontist in the Rhode Island accepts referrals from
Yeah,
our clinic.
that is
Well,
great. Well,
you're not alone. That's kind of nationwide. You have no idea how helpful these lectures have been. And thank you for signing on, and we'll keep giving them.
that's what I'm.
Thank you. Yeah.
All right. Yeah, I def.
Right. Right.
All right, well, I think that just about concludes our presentation here tonight. I'd like to thank you all for your participation in the Primary Care for All webinar series. Very special thanks to Drs. Rico Short and Roy Brooks for an insightful and engaging presentation. This has been recorded and will be stored in our on-demand section for your review. I would also be negligent if I did not give a very special thanks to our tech team. Quallen, way to go. Couldn't have done it without you. You are also invited to our Tuesday coffee shop on November 15th. That's next Tuesday, in a very special core-wide coffee shop, Instant Recess with Dr. Tony Yancey. And I spoke to her office this afternoon, and I've got another meeting with them tomorrow, and you guys are in for a very special treat next week. That's going to be a goodie. Also, next Wednesday, November 16th, we have the topic Addressing Sexuality with Pediatric Patients and Families. Tips for Encouraging a Lifetime of Conversation with Dr. Carrie Bayer. Again, this series is made possible through a partnership which
Thank
allows Primary Care for All to serve as a resource for